Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, Dr. Dan and I are talking about primary care champions, nurturing a healthier tomorrow. Let's dive right in.
Hey Faisel, how are you?
I have to start off by telling you that although my office looks wonderfully clean because I asked my wife to find me my travel information this past weekend. Remember I forgot my laptop and phone. So she saw the state of affairs in my office and turned it into something. You could take a picture of this and put it in a magazine somewhere. I mean, it looks beautiful, except I have no idea where anything is.
My office always looks like a disaster, but I know where everything is, so it's good.
Even this angle is different for me. I'm thinking, oh my God, this thing is too high. I got to bring it, But anyways, there's so much that has happened, with going to the annual FMEC meeting in Providence, which is always fun. It's just great being around the students, the residents, the faculty. But this year, one of the themes that I heard over and over was about the state of affairs of the health of the country.
Right.
Rather than talking about it from the perspective of, we're spending over $4.5 trillion and we're wasting over $1 trillion with all this unnecessary stuff. Now it's getting to the point where hey, other similar countries are doing much, much better than what we are.
Right.
And now there's more even in the public about countries like Costa Rica having better health outcomes than us in a way that you can visualize it. It's not just in a list in a paper that, hey, this country, we're ranked this and that. I mean, it's starting to become more palpable that the health of the nation is not doing well.
Right. And I think we know that primary care is the one, number one, when you look at other countries, right? So you say we spend more on healthcare than any other country. And that is true. But if you look at our per capita spending on social programs, we're towards the bottom of that. So we spend more on healthcare, less on social programs, and yet we get worse health outcomes. And then we also know that the only specialties that improve outcomes and lower costs are the primary care specialties. And yet we're split 70-30 the wrong direction, right? We have 70% of our physicians in this country are subspecialists and only 30% are the primary care specialists. I think it's frustrating. I know it's frustrating I know we've had a few people from the different NASM reports on, and they've talked about we need to implement high quality primary care in order to improve the outcomes. And I can imagine that the faculty feel like, well, we know we have the answer and we're able to train people, but we're not getting the support we need to do that. And so I think that's the thing that's frustrating. Hospitals are still getting paid to deliver volumes, not to deliver outcomes. And anyway, I think that's what's going on. And I think I did get the impression that people are feeling frustrated by not having the resources to train the providers they need in the newer advanced models of primary care.
Yeah. And then we've also become so consumer centric. What if what the patient wants is not in his or her best interest? Another point that came up that felt much more palpable hearing it from the mouths of the doctors in some of the smaller communities where primary care, just access to any primary care is so limited with all these urgent cares and standalone emergency rooms propping up, and even some of the paying clinics where people are paying essentially hey, I am paying you money. I have an earache. I'm just picking on the earaches, right? It's a sensitive subject for me, very personal. It resulted in me getting a CT scan.
All right.
But yeah, we've got the earache situation that does not require antibiotics. But hey, I'm going to give you a bad review if you don't give me what I came here for.
I know people get frustrated by that, but it really is about building the relationship with the patients. I mean, I think the big place where we've had to deal with that, and I not so much at the company that we work for now, but in my past life, I would have doctors using that as an excuse to give patients opiates. Well, they're going to not give me a high mark if I don't give them opiates. And so we really, I think it's always been the case that you've got to build the relationship, and then you've got to get the patients to buy in to the proper treatment. We're not a McDonald's. We're not a short order cook. You don't get to come in and just order what you want. And ultimately, there are limits even when you're doing that. I mean, the urgent care facilities and the emergency rooms they have limits on what they can do. But I mean, I think I've heard that you've got to give the primary care provider time to build the relationship with the patient. And as I've heard you talk about getting primary care in all the wrong places. And so, having used to moonlight in an emergency room, I mean, if somebody came in with an earache, I was concerned about having the beds open for the next chest pain or the next chainsaw injury or the next car accident. And so you're right. I would occasionally write prescriptions for antibiotics just to move people along their way.
Not you, Dr. Dan. No way. No
But
way.
that was because again, it's our colleagues in healthcare and the emergency medicine doctors. The most frustrating thing in the world for them is to have their administrators pushing primary care into the emergency room anyway. That's not the reason they chose to go into emergency medicine. They want the blood and the gore and the high acuities. What the reason they went into that? So they're not looking forward to seeing the low acuity illness if they don't have to.
Is it safe to say then that, because what I heard you say, when I was going down the rabbit hole with all the problems with the consumer centric stuff is, well, Faisal, the focus needs to be on relationships, long term relationships.
Yes.
And then once you restore these long term relationships, does it have to be with a doctor or could it be the system itself?
Well, I would think there could be a lot more that we could do to build relationships with systems. I mean, I think we tend to have relationships one on one with people, but it's interesting. Every time you go to the doctor, they have you fill out the same forms, right? All the same forms with all the same medical history. Yet, I bet I haven't bought anything from an LL Bean catalog in 5 years. But if I called them this afternoon and said, I want a pair of these pants, they would say, this is the size you bought the last time. Is that still the appropriate size or has something changed? And they would have a record of everything that I had, all the end. Now, it's a lot simpler to have a pant size stored than to have all the medical history stored. But, we've talked a lot about your dad and the price of computer storage. And computer storage now is almost free and unlimited. So there's really not a reason not to be storing all these different data fields. And there's no reason to have to re-answer the same questions over and over again.
Even with the same practice. My dentist, I love my dentist, love adore my dentist, let's put that out there. I adore the people who work there, even the billing people, everybody front desk, all that. But this morning I had to refill out a sheet of paper. And I said, well, nothing's changed. I've gotten a year older, but nothing's changed from last year to this year. Well, we need it. Well, you have your computer there. I got to fill this out. I got to fill out all this in the paper. Dr. Dan, it definitely looked like a doctor filled out that piece of paper. And I said, there. And I just thought to myself, my gosh, how are we still doing this? Because I didn't, even though I know I have an amazing relationship with the clinical team there and even the billing people and everyone, it's a nice system, very, high tech with letting me know what's going on, high tech and the experience, with the education for me, the detailed imaging. And I was suggesting to them, hey, they got to be a little bit more aggressive. So despite me having that feeling of a great relationship with them, the system just makes you feel like you're a stranger all over again.
Well, and so what that means that our relationships tend to be human and personal. And I think going forward, I think we do need to have better relationships with systems. But I also think it's important that we have access to the person you can trust to ask the question of, right? Because I know that I think we always take that very seriously when people trust us. I'm dealing with a patient I saw last week with some weird symptoms. And, I pushed through a bunch of expedited labs and x-rays yesterday, and it looks like, something pretty serious is going on. And so now I'm sort of working through that workup for him. But I know that he called me on Friday and I said, he said he couldn't come in until Monday. And I said, well, I'm not going to be in the office seeing patients until Wednesday, but I'll get somebody else to see you. And he was like, no, I want to see you. I think we all sort of have that human trust thing, especially when things get serious, right? When you think there might be something going on, you want to talk to somebody that you've got a relationship with.
That's what leads to the better health outcomes. If you want to go about it all different ways, like how can we reduce the cost, have better health outcomes? I just don't see a way you can do it like that level of intimacy, that level, that feeling. You don't want to feel like just grateful for whatever little crumbs you get when it concerns your health, right? Like when you need it, especially when you need it. You don't want to have barriers put up to you when you're terrified about, your health or your quality of life or anything like that. But that's the way many people feel. And I really don't know outside of, say, like a direct primary care model. If you're in a direct primary care model, a direct primary care relationship where you're paying for that relationship. Essentially, you're paying for that relationship, right? And then through that relationship you have with the doctor, there's like this mutual situation that benefits both sides, where once you trust the doctor and the doctor trusts you, beautiful things happen that that the doctor has, your best interests. And then in our world, where you take that out of the equation, I don't really think about. I haven't thought about.
Well, we take care of the complex, chronically ill patients with low income, but we cap panels at about 450 patients. So, I mean, there was no question when I was talking to this patient the other day, I knew that Wednesday morning, I didn't know what my schedule was, but I knew that I was going to see him no matter what. We'd just be there at 8:30 Wednesday morning and we'll sort it out. And I knew that we would have time to do it. But it's so many of the practices get their schedules so jammed that they don't have time to allow their regular patients to come in when they're sick, because the people running the offices want to make maximum utilization of the office space and the staff. And so they don't like for you to leave openings, even though we know that people are going to get sick and need to be seen that aren't going to be pre-scheduled. I mean, it would be great if I knew I was going to have my heart attack in 3 years and I could get ready for it and know that we could get it scheduled. But that's not the way it happens, right?
Okay, God forbid, let this. Yeah, unfortunately, life's emergencies don't happen on a schedule like that, Dr. Dan. I'm sorry. Let's go back to Dr. Dan, rural Virginia, starting off your practice. And now that you remember that mindset you had there, I mean, you were excited to get your practice started and be that doctor, right? How many staff did you have for yourself? And how many staff do you wish you could have for yourself, looking after the population of people you're looking at the peak of it all, before anybody else, no help from any other clinician? No, and then the other part of that was that, do you as a doctor need to be the one, if you're having to make this transition, do you as a doctor need to be the one doing all the preventive care work? Do you have the time? Do you have the time?
Well, the question is, do you have the time? But then how do you convince people to do it? I mean, I always had this idea that if the system worked well, that patients, just by interacting with the system, would get all the preventive care taken care of, right? It would get ordered automatically. They would show up. And I mean, that's not like we do that right now on a fairly small basis, but we do get regular reminders for flu shots and mammograms and all of that. And so in theory, it would get ordered automatically to do that. But the other thing I realize is it generally does take a conversation, because people feel like they don't want to do it. And so you have to have a way that the people who don't do it, they come in and you have the conversation about why you need to do it.
Like, how do we double flu shots? We can't double it in the current system. So then I'm wondering, what else do we need to be the ones doing it? Or should it be other places? Should it be like just part of going to the grocery store? In the same way that
that's where my wife gets her flu shots, at the grocery store. So I think we see that in a lot of places. But then the issue is, how does that information track back to her doctors? And the simple answer is right now, not very well. It doesn't make any sense to me. I got a little card in my wallet that I can go stick in these holes in the wall and it'll spit money out of me. But it's amazing that my bank always finds out that I took money out, right? I mean, I've never taken money out. I mean, I've been in other countries, I've been on other continents, and I've taken money out of one of those holes in the wall. But by the time I get home, my bank always knows where the money went to, right? Why can't we do that with health information?
Would that be one of the main investments that you'd recommend making with when we're talking about investing in the primary care infrastructure, that one of the first places we got to start is how it all talks to each other?
Well, and I think we need to the information should be the patient's, and so the patient should have the control of the information, and they should have it should be they can give you the password, and whoever they give their password to, you can just go get it. It's not right now. It's owned by whoever did the study, and the patient has access to it. We should say that the patient paid for it or somebody paid for it on their behalf, and they have the information, and they should be able to give it to whoever they want to. But I don't know that spending more is necessarily the answer, because we all have so many phone numbers, right? I mean, I've got two cell phones. I've got a phone number through the Ring Central app through the company that I have. There's a home phone number that I don't ever use. I don't even have a home phone hooked up to it, but there's a phone number associated with that. And then, the Doximity app, I have a fax number with that, so somebody can fax direct to my cell phone, because people still want to use fax machines. And so I can't give them an email, so I've got to give them a phone number that they can fax it to me. And so I can get that too.
It's like when I'm here, like if we're looking at the finances, I use Bank of America for my banking. Bank of America knows everything about everything, but Chase Bank has no clue. Chase Bank has a small little view of my financial situation based on my general credit history, whatever the three credit bureau, whatever the credit. We just need somebody to overall say that, hey, he's got a score of 720 right now, but a couple of years ago he was down to 560 because of some poor financial decisions. But now he's back up. He's back up and he's doing well. So then I can go to this place or that place and they'll treat me differently based on what my health score is. Because right now that doesn't exist. That just doesn't exist. So the infrastructure needs to be invested in.
Right. And then we need a way to, again, for the primary care physician to be able to direct the care rather than the insurance company hiring case managers. I think you've heard my analogy. When we're hiring somebody, I'm looking for somebody to help me take the garbage out. I'm not looking for somebody to tell me the trash can is full. But so many of the case managers that work, I still remember very well, again, in my prior life, a case manager from one of the insurance companies calling me to tell me, that I needed to do something about my patient's hemoglobin A1C. And I'm like, oh, you mean my patient who also has problems with alcoholism, who just had a falling out with his wife and now is essentially homeless? You think that the hemoglobin A1C is my number one priority. And I mean, this hemoglobin A1C was like 8.5, right? I mean, it wasn't acutely dangerous. We needed to get his social situation stabilized before we had any chance at all on addressing his hemoglobin A1C. But they kept asking me what was I going to do about the hemoglobin A1C, and the simple answer was that day I was doing nothing about the hemoglobin A1C. That was not the highest priority. I wasn't even going to engage the patient on the hemoglobin A1C. I needed to engage him on other things. So
if the recommendation is not to spend more money, but we realized that a big chunk of our medical training was in the walls dealing with the problems, right? In the walls of the hospital. And it was great times. I mean, some of the best times. I mean, I think we both agree those are some of the best times of our lives. I mean, it's hectic, obviously. It's the best and the worst times, hands down. It's the best and worst times. Do we need more training? Do we need more than 3 years? Do we need 4 years? Do we need 5 years?
well, and then the question is, how much of it has to be under direct supervision, or do you need mentoring when you come out? And the answer is you probably need the mentoring when you come out. I mean, I know there are some 4-year family medicine residency programs. I think it's about 5 years into practice when people sort of hit their peak as far as if they're in the right environment and they have the right resources and the right mentoring, that's when you're sort of at your peak of your skills. And actually, there's studies that show that the people are sort of at their peak of medical knowledge at about 5 years out of residency, too. I don't know what that says about me, that a lot more than 5 years out of residency, but I think to be able to get that continuing mentoring is important. So many people are just sort of pitched out, when they finish residency, and then they go somewhere and there's not the doctor's lounge to have conversations. I mean, I just right before we started, again, I was telling you about the patient that was really complicated, and I ordered a plain film yesterday, and I wanted it done quickly, so they sent him to an outside hospital. And now I know I'm going to need some more diagnostic studies, so I called to speak to a radiologist, and took me like getting transferred to 3 lines, and then radiologists are just always stunned that somebody actually calls and asks for their opinion about what test you should order. But I needed some advice as to, what test, and do it with contrast or without contrast. And is this a reasonable way to work this up? Or is there one of these new fangled things that would be better? And we came to an agreement pretty quickly, but I could tell that he's not used to getting these phone calls anymore.
I know, but poor radiologists and poor pathologists, right? Even in retirement, they get excited if you call.
That's right. But I mean, you think about it, before you would be in the hospital dining room and you would see you might not even know you have a question, but then you would see Joe, the gastroenterologist, and you'd think about your patient with abdominal pain, and you'd walk up and say, Joe, the GGT is a little bit elevated on this patient. It doesn't quite fit. What do you think? What should I do? And everybody was always very free with sharing their advice. And they would say, do you want me to come by and see them? And you could say yes, or no, let me order this next study, and then if I need you, I'll call you. Don't want to waste your time. I think it worked out that way. And how do we get back to that?
Because they didn't view you as a walk-in, just interrupting their schedule.
Right.
They viewed you as a physician in need.
That's right.
I said, a physician in need is a physician indeed. And they felt good. They felt good, and we felt good. It was mutual. And most of the time, it wasn't that you were going in the wrong direction. Most of the time, we just needed that reassurance. I remember. It was great. I mean, if that held true as interns and residents, of course, in practice, I just don't know how our medical education can invest in the people to really handle this, respond well to all these social issues. Because right now, I mean, if you would have asked me in those early years to address those social issues, I would have told you the same thing, like what we hear a lot of residents telling us now. I'm a doctor, not a social worker.
So, I think the ACGME is certainly working on addressing the social determinants of health, but I think how you pay for primary care, somehow you have to, through policy, make sure that money gets to the frontline primary care, not that it gets, because we know a significant percentage, I mean, the number we've heard, something like 70% of primary care physicians are working in hospital-owned systems, and probably a similar number, maybe even more than that, for residents or training in those systems. So the money comes in at the top, and how much trickles actually down to the office. And traditionally, you've thought of primary care as being the loss leader. But yet, if you want them to learn about these social things, it really helps to have a social worker in the system that they're interacting with, so they learn how they approach that. It doesn't mean that they have to do everything. You do have to have some, just like treating chest pain. I mean, you get a lot of reps at that. Probably need reps at how you deal with somebody with housing insecurity or food insecurity or whatever. I mean, in any given area, there's a limited number of things to do, but you've got to see the different things. And honestly, that's nothing that we get taught in medical school.
Because right now, I mean, what incentive do the major employers have to say, hey, we're going to pay off your student loans? They don't have an incentive right now. So I feel like an incentive needs to be created to entice more of the students to pursue these primary care tracks, at least with the student loan. If that's that's another theme that came up over and over again. We were at FMEC, is the student loan debt amount being such a major driver with what fields, what residencies, and what even after residency, what careers that even family medicine residents, end up pursuing. I met a resident who wants to work as an ICU doctor. It was unbelievable. She said, I want to do I'm going to work in these underserved areas, but my passion is working with the with patients who are critically ill, and I want to do locums work to keep my up.
Yeah, I was just listening to a talk. Wendy Dean has her book about moral injury healthcare, but she quoted a statistic, and so I think it's probably accurate. So for every physician, there's 17 other physicians in the country, right? And only 6 of them are actually touching patients, and the others are doing administration or something like that. So how do we actually support the people that are actually there on the front lines? I mean, and I know I can remember, I think I was privileged because I got to start a practice right out of residency as part of an academic center. And then I got to do essentially nothing but see patients. I did some clinical teaching, but I didn't have any administrative duties, and nobody was pushing me to do research or publish for 5 years. So I got to do that 5 years and really got a lot of skill there. And now there's often the idea, how do I buy my time? How do I get to do something so I'm not taking care of patients day in and day out? And, I wonder if part of that is because of the grind of the computers. And so hopefully AI is going to fix this going forward so that it will be more fun again to be the doctor in clinic, and it won't be such a grind to try and get everything done.
I don't know, but the ones who are benefiting from all the inefficiencies, I can see them putting up a lot of resistance. Well, thank you so much, Dr. Dan, for another great conversation. One thing that somebody said also is that, we could learn a lot from these other countries. And I said, yeah, but, countries like Denmark, who've made these switches. If one of our smaller states figured out a way forward, I say, super, that's great. It's amazing that you could drive around your state in a couple hours and you figured it out. That's fabulous. But to do it for the entire country with all these different political forces at play,
Yeah, well, and I think there's some spots going well. I think Maryland is doing some really interesting stuff about their capitated payments and about their primary care incentives that they are offering now, especially for the patients with the problems with social determinants of health. And so I think when you're talking about smaller states, I think Massachusetts has done some work on primary care spending. And so I think it could happen. I like to be an optimist. I think it could happen here. So we just need people to roll up their sleeves and do it. And Florida could do it too, Faisel.
Dr. Dan, I'd like to think of myself as an optimist. But when one of the best presentations that we heard from FMEC is about a grassroots movement, and now with the ability to connect people to get these sort of grassroots initiatives moving towards even these dramatic ideas like primary care for everyone. If there's a will, there's a lot more of an easier way now than I think ever before. Yeah, I'm with you.
What are your thoughts on primary care champions nurturing a healthier tomorrow? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.